In this video, I'll argue for something that may seem esoteric, that primary progressive MS and secondary progressive MS are the same disease, but it's not. At the end of the video, I'll show why this has significant implications for people living with MS. But first, I'll show strong evidence that SPMS and PPMS are the same disease, both clinically and biologically, without significant differences or different implications for treatment. Remember what Dr. Lucas Shalua said, "Paradigm shift is for the mindful, but those who refuse to adopt new ways of looking at things will always catch yesterday's train, flight, or bus." I'll start with a brief review of the different MS subtypes. In these three graphs, the x-axis is time and the y-axis is increasing disability. In relapsing remitting MS, or RRMS, there are often periods of remission where symptoms are stable, and then there are attacks, depicted by the red lines, where symptoms are getting worse, also known as flares, exacerbations, and relapses, followed by some improvement, complete or incomplete, and then periods of remission. Some people with relapsing MS, as they get older, they may stop having relapses and start slowly getting worse over time, insidiously over months or years, often described as greater difficulty walking long distances, but it can affect other symptoms such as clumsiness or even cognitive symptoms. And this is known as secondary progressive MS, SPMS, because the second type of MS is the progressive form, whereas the first form was the relapsing form. But some people have never had an attack or relapse in their life, and their first symptoms are just slowly getting worse over time, depicted by the slow upward curve, primary progressive MS. It's primary because it's the first form of MS. Now, in real life, people don't necessarily progress forever. People often have periods where they're stable with plateaus, but overall they may be slowly getting worse over many, many years. Now, from the doctor's perspective, it can be quite difficult to know if someone has primary or secondary progressive MS. For instance, I saw a patient recently in his 50s who clearly had progressive MS, but retrospectively, he reported many symptoms highly typical of multiple sclerosis relapses. He was just never diagnosed with MS, so I believe he has secondary progressive MS, but sometimes it's not so clear. Let's say you have progressive MS and you say, hey, 10 years ago, my right hand went numb. Was it a multiple sclerosis flare or carpal tunnel syndrome? It can be hard to know 100%, so you can see right away these multiple sclerosis subtypes are a little bit arbitrary, and we're going to focus on, is there a distinction between SPMS and PPMS? But regardless of my opinion, people seem to think these are different diseases and in fact may require different treatments because clinical trials specifically often study either PPMS or SPMS. For instance, rituximab in the Olympus trial for PPMS, Ocrevus in the Oratorio trial, Gilenya in the Inform study for SPMS, Simvastatin in the MS-STAT study, Mayzent, Novantrone, Avonex. But other studies just write chronic progressive multiple sclerosis. They'll take both forms. For instance, biotin, methotrexate, intravenous cladribine, hematopoietic stem cell transplant, and abutolast. So who is right? In my opinion, the people running these second trials. I'll show you why. We start with radiology. The MRI scan, the key diagnostic test in MS, cannot distinguish between SPMS and PPMS. If we look at T2 sequences on the bottom here, we see lesions in similar areas, periventricular lesions around the ventricles, the subcortical white matter, the juxtacortical white matter right beneath the cortex, also the corpus callosum connecting the two halves of the brain, the brainstem, and the spinal cord. If we look at T1 sequences, we can see these low-intensity lesions, so-called dark holes, and there can be accelerated atrophy or brain shrinkage in MS. Can an experienced neuroradiologist tell the difference between SPMS and PPMS by looking at someone's scans? Absolutely not. But what if we do a biopsy of your lesions, or if you pass away and we do an autopsy? Can we tell the difference between SPMS and PPMS? Again, the answer is no. We see similar features in both diseases. Of course, there's demyelination, loss of myelin, the fatty sheath of nerve fibers. We see inflammation with infiltrates of primarily T lymphocytes, but also some B cells and plasma cells. This is a hematoxylin eosin stain showing a lymphocytic infiltrate with some histiocytes. We can also see activation of the resident macrophages or microglia. Even the meninges, the coverings of the brain, can be inflamed, and we can see gliosis or scarring around lesions, and when damage is more severe, we can see damage to the nerve fibers or axons themselves and loss of neurons. And even cell biology studies show similar findings: oxidative stress and injury and damage to the mitochondria, the energy-producing organelles of the cells. They're virtually identical. But what about the clinical features of MS? Is the prognosis or the symptoms different between SPMS and PPMS? Well, this is a natural history study from Ontario done a long time ago, before there were any disease-modifying therapies, comparing SPMS, the gray lines, versus PPMS, the dark lines. One of the authors is the famous professor George Beaber, and it uses the EDSS scale, Expanded Disability Status Scale, a measurement of disability in multiple sclerosis research. They look at DSS-6, needing a cane to walk 100 meters, DSS-8, requiring a wheelchair with significant amount of disability, and DSS-10, death due to MS. And you can see the lines for SPMS and PPMS very closely overlap with each other. Perhaps for DSS-8 and 10, there's a slight worse prognosis with PPMS, but really the lines are very close to each other for almost the entire duration of disease. Now, interestingly, there may be a slightly different sex ratio for SPMS and PPMS. This is data from Newfoundland and Labrador, and similar results have been found in other studies. Let's focus on SPMS and PPMS and the gender ratio. You can see for SPMS, they reported 67 females and only 27 males, a sex ratio of 2.48 to 1 females to males. But for PPMS, it was 42 females to 24 males, a sex ratio of 1.75 to 1. So men seem to be slightly overrepresented in PPMS. It could be because men are, for whatever reason, less likely to have attacks earlier in the disease, or it could be that MS is less recognized in men, and so relapses are underdiagnosed, and men may be falsely reassured even after having symptoms typical of MS. Now, some studies do report that PPMS is a little bit worse in terms of prognosis, but in my opinion, this is very misleading, and I'll explain why I think that. This is a Polish study looking at time to EDSS-6. How long does it take until people need a cane? And you can see people with PPMS in the solid line versus SPMS, the dotted line, tend to need a cane sooner. But when exactly is the start point? People with SPMS, they already have a diagnosis of relapsing MS, so they're going to notice progression of their disease and immediately get diagnosed during the transitional phase. Whereas people with PPMS, they don't even know they have anything at all. I've had patients tell me at first I thought I was just getting older, or I attributed my symptoms to arthritis or something else, so they tend to get diagnosed a little bit later. So this is a little bit misleading. A more objective way to do it would be to compare how long it takes to get from one level of disability to another, so the starting point is exactly the same. This is data from MS-BASE, a multiple sclerosis registry, looking at how long does it take to go from EDSS-4, moderate disability, to EDSS-6, requiring a cane. And you can see relapsing remitting onset in the dark line actually does worse with progressive onset. Many of these people, by the time they get to EDSS-6, do in fact have secondary progressive MS. The same is true from going from a cane to a wheelchair, EDSS 7.0, requiring a wheelchair for long distances but being able to walk short distances. Here the lines are right on top of each other, and at the end you can see people with relapsing onset disease maybe doing only a little bit better. Another way to do this is to look at clinical trial results and look at progression in the placebo group. So this column on the right is the Olympus trial, which is a randomized trial looking at rituximab in primary progressive MS versus placebo, so this will represent PPMS. And on the left is the IMPACT trial, an old study of Avonex versus placebo in secondary progressive MS. And these studies were done at a similar time, and you would expect the baseline characteristics to be similar, except for the difference in subtype. You can see their age was fairly similar, 47.9 on average versus 49.6. There were slightly fewer females in the Olympus trial, only 55% females versus 64%, which makes sense based on what I said earlier. There were slightly more active or enhancing lesions in the secondary progressive MS group, 34.4% versus 25.2%. You can see a significant difference in time since first symptom and diagnosis, which makes sense given the difference in subtypes, and their disability at baseline was fairly similar, EDSS of 5.2 in the SPMS trial versus 4.7. But now let's look at their progression. This is a chart comparing progression again in the placebo group. It would be unfair to compare the treatment groups because they're different drugs, and rituximab is known to be much more effective than Avonex. And they compared progression in the placebo group of MRI findings, the EDSS score, the EDSS functional system scores, the timed 25-foot walk, the 9-hell peg test, which is a measure of upper extremity coordination in MS, the PACE-SAT, a measure of cognitive function, and there were 0 statistically significant differences, none, and you would expect maybe there would be 1 or 2 just by random chance. There was no difference. This study looks at the rate of brain atrophy or brain shrinkage in different forms of multiple sclerosis. In the general population, the brain shrinks with normal aging at a rate of about 0.2% per year, and you can see the rate of brain atrophy on average is roughly the same in primary progressive MS and secondary progressive MS, and interestingly also the same in relapsing remitting MS, even in people who report that they are stable in remission, and even in clinically isolated syndrome, and roughly speaking it averages around a loss of 0.4% per year, greater than the general population, but with a lot of individual variation in some people not with accelerated brain atrophy. And this really supports the idea that MS is one disease. This study looks at the genes of people with different forms of MS. So they looked at genes like HLA-DRB1-1501, which is the gene most strongly linked to MS, and other genes, and they came up with an MSGB or MS genetic burden. And if these are different diseases, there should be different genes associated with them. But it looks like they were the same. The MSGB was the same in all forms of MS. They looked at relapsing remitting MS, secondary progressive MS, primary progressive MS, even progressive relapsing MS, where people with progressive MS, primary progressive MS, later have relapses. They used the spouses as a control, who of course on average had less genes associated with MS. And you can see there's a huge overlap because MS is really not a genetic disease. They're just genes that increase their risk of MS. And there's this idea that maybe relapses aren't as important as we think they are in determining long-term disability. Maybe it's more about the timing and rate of progressive MS. Maybe you can have some relapses, recover from them, but not develop progressive MS and do fairly well. This is one cohort looking at time to EDSS 6.0, in other words, time until you need a cane, and you can see it didn't really matter if people had 1 to 2 relapses, 3 to 4 relapses, or more than 5 relapses. The rate of people needing a cane was approximately the same, and they converted this to a hazard ratio compared to no relapses, in other words, people with primary progressive MS, and they're all roughly 1, in other words, no significant difference whether you have more or less relapses. Though it really depends on the relapse, and in fact, this study showed that relapses within the first 2 years of the disease very significantly affect the prognosis. This again is time to DSS-6, needing a cane to walk 100 meters. Those with 1 relapse took on average 22.7 years to need a cane, whereas those with 3 relapses or more 15.1 years. This is a 7.6 year difference, so perhaps stopping those early relapses is very important. Now, of course, relapsing MS and progressive MS are different diseases. This is a study comparing relapsing remitting MS and primary progressive MS, and it's a survival curve of survival, time until death from symptom onset. And you can see people with primary progressive MS die much sooner than those with relapsing remitting MS. Or do they? This is the same survival curve, but from birth instead of from disease onset. You see, people with PPMS tend to be diagnosed later, but they actually live about as long as people with relapsing remitting MS. They just sort of skipped the relapsing phase. And there's very strong evidence that the biological onset of MS is long before the symptom onset in many, if not almost all individuals. For instance, people with multiple sclerosis often have many obviously old chronic lesions on MRI scans. Some people have MRI scans for unrelated reasons, like a car accident, and they may have lesions that look very typical of multiple sclerosis, but no symptoms. This is known as radiologically isolated syndromes, but they may develop symptoms of MS years later, again proving the disease starts prior to symptom onset. And people with primary progressive MS, they may be an extreme example where the disease started long before symptom onset. In fact, the rate of primary progressive MS seems to be going down. This is from 2016 from the SPMS registry, a different multiple sclerosis registry, and you can see the rate of PPMS per capita is going down in all age groups, even though the overall prevalence of MS is going up. The only plausible explanation for this, in my opinion, is we're getting better at diagnosing MS. People with more subtle symptoms are getting MRI scans, seeing neurologists, and getting diagnosed earlier with relapsing MS. And I have a few other miscellaneous arguments. For instance, if you look at different ethnicities, the rate of MS can be very different. For instance, Asians have roughly 1/10 the risk of multiple sclerosis compared to Caucasian, but the distribution of different subtypes is approximately the same. There are some exceptions. Maybe in the United States, African Americans have a slightly higher risk of primary progressive MS, but there really aren't huge differences. Also, there are some families that seem to have a very high risk of multiple sclerosis with numerous family members with the disease, but usually all different subtypes are represented, and that is my experience with people with MS who have family members with the disease, which is about 30% of people with MS, that they tend to have different subtypes. There's really no tendency for the same subtype to run in a family. Again, if SPMS and PPMS were different diseases, you would expect there could be one family where they tend to have PPMS and another family where they tend to have relapsing remitting MS that could turn into SPMS, but that's just not the case. Now, I said at the beginning of the video that this is not a trivial matter and it's quite important, and I'll tell you why I think that is. Now, progressive multiple sclerosis can be a treatable disease. I have patients who have been extremely stable on treatment and are doing quite well, but unfortunately others aren't doing so well and are progressing despite highly effective disease-modifying therapy, and so we need to do better. And the way we can do better is to have new clinical trials, both for lifestyle interventions and pharmaceutical drugs and other methodologies as well. And it's really difficult and expensive to do clinical trials, and it would be great if we would have more people who could participate in a clinical trial, and the way we could do that is by combining SPMS and PPMS into just progressive MS, or people with a certain score or higher on the EDSS scale. So we can say, hey, people who have a little bit more advanced MS with more disability, could this drug or other treatment work for them? We'll see more new products, and we'll see those new products more applicable to more people. Another thing is treatment guidelines. A lot of the treatment guidelines are trying to be evidence-based. For instance, they may recommend Mayzent could be an option for people only with secondary progressive MS and not for primary progressive MS. But in my opinion, it really doesn't make sense to do that. And that's not to say that everyone with MS is exactly the same. Some people may be much higher risk for complications of immunosuppressant drugs and may not be a good candidate for a certain medication. There's some evidence that certain drugs may be more effective in people with active lesions, with relapses, with gadolinium-enhancing lesions. There's also evidence that certain drugs may be more effective in younger people, for instance. And maybe that could be incorporated into treatment guidelines, but there's simply no good reason to make a distinction between primary and secondary progressive MS. And of course, related to that is product labels. You have the labels of drugs that insurance companies are using that say specifically secondary progressive MS versus primary progressive MS, and that just makes absolutely no sense. For instance, if someone who's 40 years old and has GAD-positive lesions is going to benefit from Ocrevus if they have primary progressive MS, but they wouldn't if they have secondary progressive MS, that just makes absolutely no sense. And I think combining it into progressive MS, or even just using disability cutoffs, would be much more practical and beneficial to the MS community. And I would encourage you to look at the links below for my resources, but I want to give a shout out to one special resources because I did plagiarize this very extensively. It's a presentation given in 2013 by Dr. Volker Napper experts who actually works for a drug company, Teva Pharmaceuticals, that markets Copaxone glatiramer acetate, which, by the way, in my opinion, has no convincing evidence in any form of progressive multiple sclerosis. Perhaps they have a nefarious agenda here, trying to broaden the product label, but I do think they provided some very good and convincing data. The one thing I would say back to them is, hey, if you want to market your drugs to everyone with MS, you have to do studies in everyone with MS, and that includes older people with MS and people with more advanced disabilities. And I'd be interested to know if you, the viewer, are convinced by my argument. Do you think SPMS and PPMS are the same, or do you think there are differences? Tell me why in the comments below. And I'd like some feedback on this type of video. Obviously, this is a very technical video that may not have direct clinical applicability. It's not like it's going to make you better tomorrow. I think it's important in the long run. Do you like this type of video that's a bit more theoretical, or do you want something that you could act on right away? Let me know, and let me know if you have other video suggestions in the comments below.